This meeting is being recorded.
Thank you so much for joining us today for the Infectious Diseases panel to discuss vaccines, viruses, and the ACIP updates. My name is Christina Sire.
Thank you.
I will be introducing our moderator before we hand things over. Welcome, Dr. Lukasz Weiner. Thank you so much for being our moderator today. Dr. Weiner is a clinical associate professor of pediatrics, specializing in infectious diseases, and serves as the clinical division director of the Pediatric Infectious Diseases Division and medical director of pediatric antimicrobial stewardship at the University of Iowa Stead Family Children's Hospital. He completed his medical training at the Medical University of Lublin and advanced training in pediatric infectious diseases at Rainbow Babies and Children's Hospital in Cleveland, Ohio. So welcome. Thank you so much for being our moderator. I'm going to hand it over to you, but first stop sharing my screen so you don't have to keep looking at that. But feel free to take it over, Dr. Weiner.
Thank you, Christina. Hi, everybody. Good afternoon. My name is Lukasz Weiner. I'm one of the Peds ID docs. Thank you so much for everyone for being here. I am really honored to moderate this panel, which will hopefully help inform our providers and our public about the trends and hot topics that are emerging in the infectious disease realm of pediatrics. I am joined by our esteemed panelists, Dr. Ashlesha Kaushik, Dr. Joel Waddell, and Dr. Nathan Boonstra, each bringing their expertise and insight into this discussion we'll be having today. So let me start off with some introductions for our panelists. Dr. Ashlesha Kaushik serves as the medical director for pediatric infectious diseases and director of the antimicrobial stewardship program at the Unity Point Health St. Luke's in Sioux City, and also holds an academic appointment as clinical associate professor at the University of Iowa Carver College of Medicine. She also serves as the president-elect for the Iowa chapter of AAP and chair of the Infectious Disease Committee. Dr. Joel Waddell is a pediatric infectious disease physician at the Blank Children's Hospital in Des Moines. He serves as the chair of the Vaccine Oversight Committee for Unity Point Clinics. He also serves as the infection prevention officer for Blank Children's Hospital. Dr. Nathan Boonstra is a general pediatrician at Blank Children's Hospital in Des Moines and is passionate about educating families on the importance of public health and safety with a focus on childhood immunizations. Thank you all so much for being here. I have a few questions to ask you as panelists before we open it up to attendees to ask questions. So I'm going to start in the order of our introductions. Dr. Kaushik, I'm going to start with you with our first question. What are the most concerning infectious disease trends you are seeing across the state right now?
Thank you, Dr. Weiner, and I would like to welcome everybody over here, and thanks to all our attendees for attending this panel. I guess it's a timely discussion given all that's happening at the national stage regarding vaccines. So as you know, this is an opportune time to talk about measles. I guess, you know, that's the biggest concern, top of minds of most ID providers right now and pediatricians for good reason. We are seeing nationally an upsurge of measles, and we are on the verge of actually losing our elimination status, sadly, as a nation, which is very, very concerning. Over the last week, I think the latest data reports over 1,100 cases of measles nationally, and we are already half of last year's mark already in the first 2 months. Difficult to believe, but yeah, we are here. And I guess Iowa has been a little bit fortunate in the sense that we have not had any cases reported as yet. But in South Dakota, which is just our neighboring state, we have had over 7 reported cases in the last 2 months, I believe. So very close, you know, the boundaries really, you know, as you know, infectious diseases don't respect the boundaries, and, you know, there might be a case reported soon, but hopefully not, just keeping fingers crossed. So that's one thing. And because of the upsurge, and it's being driven mostly by South Carolina at this point, we are seeing a lot of surge of cases because of unvaccinated kids, mostly in certain counties of South Carolina. And of course, it's Arizona, Utah were, you know, the initial states that were reporting high numbers as well. So I think that just brings us to the fact that measles vaccination counseling is ever more important, and education of the providers is also equally important. And Iowa Immunization Coalition, I think we are all a part of that, is doing a great job. Iowa AAP is doing its part. We are, doing several educational webinars, and I'll be also addressing the New Jersey Immunization Coalition because it's like Northeast, but then who knows it's coming, right? So it's just very, very concerning. The other things that I'm quite interestingly, seeing here is also congenital syphilis. And I've mentioned that over the past few, years, we have seen a lot of surge in this area, especially in the northwestern part of Iowa, because we cater to a lot of underserved populations from the other states as well, including Nebraska and South Dakota. So I think that has been going on, and I'm still seeing a lot of babies in my clinic. So I think those two are the big ones. And of course, we had huge numbers of pertussis last year. And already, they are reporting some cases nationally. But as far as the respiratory viruses go, and you can see if I've heard a lot of influenza B going around. In our own ICU, influenza B and RSV are the main players at this point, and they have overtaken COVID largely, but those are the numbers. And especially with the surrounding Nebraska, we were also having a lot of questions regarding influenza B. But I'll pass it on to the others. Thank you.
Yes, absolutely. People travel and so do communicable infectious diseases. Dr. Waddell, same question to you. What are the most concerning infectious disease trends you are seeing across the state right now?
Yeah, I would agree with Ashlesha about measles and syphilis. Those are definitely two things on our radar. So I won't go on about those since Ashlesha did a great job covering it. I would point out one thing that I've found is couldn't be a helping talking point about measles. I like to highlight that South Carolina actually has better MMR vaccination rates than Iowa. So it seems inevitable that we'll get measles back, and potentially in high numbers. But a couple of other infections that have kind of caught my eye here. So at least here in central Iowa, here in the Des Moines area, we've had a string of invasive group A strep infections. So we've had several really, really bad necrotizing pneumonias. And we've had a few toxic shock syndromes and even some musculoskeletal infections. So group A strep is not new, and the clinical manifestations of group A strep are not new. It does seem like a peak out of proportion of what we normally see. So, MRSA gets all the glory, but group A strep is way worse. So that's one that I think we're kind of keeping our eye on. Another one, and it has several implications. We recently redid our antibiogram, and our MSSA clendis susceptibilities have really tanked. So we used to be in the upper 70s, maybe even low 80s, and we're down to like 62%, I think, which is alarming. So I just because once you lose Clenda for that, then it kind of has a domino effect for a lot of other things. So I like to just highlight that if you don't have to treat for MRSA and you can prioritize MSSA or group A strep treatment for whatever it is, skin and soft tissue infection, osteomyelitis, if you can prioritize that, I would say go for it. But otherwise, I would agree with everything else that has kind of already been said.
I'll say I'm jealous of your Clinda susceptibility rates. Dr. Boonstra,
Sure.
can you please give us
Yeah.
your perspective on concerning?
I'm not going to have better answers than my infectious disease specialist colleagues are going to have, but from a general peds perspective, certainly the measles trending is extremely worrisome because that's something that I'm likely to start to see in the clinic if these trends continue. And then also just the fact that we know that measles being the most contagious infectious disease that we have, that's the canary in the coal mine. And so we worry about the other vaccine preventable diseases that I might start to see in the clinic as well. And whooping cough would be the one that I get nervous about from a general pediatric perspective, just because I know how quickly that can affect my patients, especially if they're unimmunized and young. So I get pretty nervous about what am I going to start to see that I haven't had to see in my practice in 20 years. And those are two of the things at the top.
We are definitely having to re-educate ourselves on some older infections, including syphilis, to be honest with you. Thank you, all of you. We'll move on to our second question. Dr. Waddell, I want to start with you. I've heard you talk about this, and I really like hearing you talk about this. But let's talk about vaccine ingredients. Despite strong safety data, myths about vaccine ingredients continue to circulate, unfortunately. Which ingredient-related misconception are you encountering most often right now? And how do you address them with patients and caregivers?
Yeah, this is a really important question, and it's getting more traction. I'll take a quick side note. If anyone's not on mute, could you mute yourself so we could? I'm a very ADHD type of guy, so I when I think of vaccine ingredients and addressing with parents, I kind of break it into two categories of parents. And the first category is parents who've never thought about this before, and they're hearing about it now, and they have just general questions like, "Am I supposed to be worried?" And for this patient population, I don't think you need to go, you don't have to be robust with your answers. I think you can just reassure them that no, these ingredients have been around for a long time, and they're safe and effective. And then follow that up with individual questions they might have. Now, if you compare that to kind of the other class of individuals who have said, I have been reading exclusively on this ingredient, I think you have to get a bit more detailed. I would say, as hard as it is for ID docs to be concise, try to be concise and to the point. And I would say don't harp on the myth too much. If you talk about the myth, what sticks with them is the myth, not your answer. But I kind of break it down with individuals who say, I'm just worried about ingredients in general and it inducing autism or other neurological diseases. And a blanket statement can be, there are fewer things on this planet in medicine that have been as well studied that these do not cause autism, neurodevelopmental disorders, etc. And sometimes that's all they need. But when individual families come in with specific questions, I have heard a lot about aluminum recently. That's getting a lot of traction. So we saw a little bit of that in the December ACIP meeting. I try to keep it short, concise, at the beginning at least. And I say aluminum is natural. It's a natural ingredient of Earth. There is more aluminum in breast milk than vaccines. There's way more aluminum in formula than vaccines. And sometimes that's what all the people need. I have found if they need more information than that, they've already made up their mind. Similarly, some come in and they said, I just learned there's formaldehyde in some vaccines. That's how you embalm people. How in the world am I supposed to inject that into my baby? So I like to remind them, formaldehyde is also natural. Like the word natural has it's caught its own wave of popularity over the last decade. It's a natural substance. It's so natural that, my key point is, there's more formaldehyde in cauliflower than vaccines. So if you're comfortable giving your child a vegetable, you should be comfortable giving them a vaccine. And mercury, I haven't gotten as much personally mercury recently. I've gotten more aluminum than others. You can always remind them why we have aluminum to make your child actually have fewer shots, why we have formaldehyde to keep them safe. But as I'm explaining being concise, I'm not being concise. So I'll stop and let someone else go, but that's kind of how I approach it.
Thank you very much. The difference between safe and toxic can be the dose, right? Dr. Boonstra,
Sure.
In your experience and what you have seen, what are some safety myths that you come across? And how
exactly
do you
the
address
same. So ingredients are, I think Dr. Waddell nailed it precisely in that you have ones that are generally concerned about too many too soon in terms of ingredients or in terms of the antigen load or just number of shots. And I do think exactly the things that Dr. Waddell mentioned about reassuring about just simple statements, reassuring about aluminum. When it comes to formaldehyde, I don't get a lot of specific questions about formaldehyde. Aluminum, yes. The other thing is I always try to back both like what I say with like a study. So there was recently a very, very good aluminum study. So I can say confidently, like also this has been studied very well, specifically aluminum, to look for long-term problems with it. And it's just not. We've looked at it a bunch of ways. And if they actually want me to send them the studies, I can do that. But again, a simple statement as far as what you know about the safety, and then say that you can back it up with studies. That's the way that I go as well. It is also, when it comes to the number of shots, reassuring, I think, to remind families that we've been able to give shots now with far less antigens and antigen stimulation than we used to be able to in the past. So, not only is it true that our immune systems can actually handle vaccines very well, it is a sliver of the amount of antigenic stimulation that we can handle. That actual antigen stimulation has gone down, which is evidenced by the fact that the DTaP vaccine that we give now is far better, far less reactogenic than the DTP vaccine that we used to give in the 80s. And so babies tolerate a lot more, and we have a lot less of that kind of that antigenic stimulation. So that's another thing. Again, I don't necessarily use that long of words to talk with families about that. But those are kind of the two things. And I agree, like part of our job is, we make those recommendations and we use an approach that answers their questions. And then they do ultimately have to, if it is kind of like, no, that's not reassuring, a lot of times families have already made up their minds. And so it's more for me than a point of like, I want to make sure that you understand my my recommendations and exactly why I'm worried about pertussis vaccination at this age, why this is important and whatnot. And we're going to keep revisiting it.
Excellent. Thank you so much, Dr. Kaushik. How do you address these ingredients concerns with patients and families?
Yeah, I completely echo all the statements, Dr. Waddell and Dr. Boonstra just said. So, like the two categories of parents, you just walk in with a presumptive recommendation and they usually agree with that. And if they have certain questions, then we pull a chair and talk to them in greater detail. And then, there's a role for motivational interviewing and stuff. But if they have, as they go with questions, you can provide your answers. Thimerosal was one thing that was asked by my office colleagues more than, the parents' families, like they were probably having these questions from patients. So again, just clarifying for the audience also, like there have been no vaccines since 2001. It was discontinued for most of the vaccines. So the majority of the vaccines we're using do not have mercury. So mercury should not be a concern. It's only used for very, only multi-dose flu vaccines, only used globally or in mass immunization campaigns, etc. So it should not be a concern. Plus, the variety of the mercury that is, usually employed for that purpose is the less toxic or the non-toxic variety, ethyl mercury, rather than the methyl mercury, which is like the more toxic, the poisonous or the toxin causing, mercury. But as such, it should not be discussed anywhere near vaccines because the ones that are available, widely used here in the United States, are not having any mercury. So that thing was just, it's an out of the box question, which is just being floated along with all the other misinformation out there. And they are trying to question aluminum, which is obviously natural. It's one of the most abundant elements, as was mentioned. And so it's like, it's a moot point, I guess. It's just that, okay, how many medicines are we taking, if we fall sick? And, those medicines can also have side effects, just look at the chemotherapeutic agents and such. Vaccines are just to keep you healthy. Only if you have not seen these diseases or not heard about them, it doesn't mean that they don't exist. They do exist in other parts of the world. And in the developing world, people are still struggling with a lot of them. And I was just on this PPN call yesterday, the Pediatric Pandemic Network national call, and they were mentioning how much measles alarm is going across the whole, country, like from different states. And they're even reporting seeing some SSPE suspected cases in Illinois. So that's like really alarming. Like if we are talking about SSPE in this day and age, then that is really alarming in this, developed country, because that's a disease that is unheard of in this part of the world. Like that's only happening in the developing countries as of last year. But sadly, here we are.
I did see a question come up about SSP, sir. That is interesting. Thank you so much. that actually segues in a way into our next question. Dr. Boonstra, I'm going to start with you this time.
Hmm?
For healthcare providers facing vaccine hesitant families, what communication strategies have you found to be most effective in keeping communications productive?
Sure. So the first thing is, I think, the initial communication, which is that what we call an announcement approach, or it's been called presumptive approach. I think Dr. Kaushik mentioned. I like to use announcement approach. I think it sounds a little bit more, I don't know, just a better way to phrase it. But that is basically making sure that not just you, but everybody in your staff is on board with making sure that the families know that these vaccines are recommended. So the announcement approach is compared to like I forget the actual term that we use, but like it's sometimes called participatory approach. Basically, the difference is you're saying when you or your staff is talking about vaccines, your baby is recommended or Dr. Boonstra recommends these vaccines that are due today, as opposed to these are the vaccines that are usually at 2 months. You and the doctor can talk about those or something like that. That makes it sound like it's kind of a smorgasbord, and then the patient is just kind of, or the family is kind of picking from that. Recognizing that as a provider, our job is to make a recommendation. That doesn't mean that the family is going to agree with the recommendation, but it is our job and responsibility to make that recommendation, not just to say, hey, these are the options for medical care. You pick what you want to get. So that is important, and that has been shown to be the number one thing when it comes to vaccine uptake is a good provider recommendation. We don't always feel like that's the case, but that is the case, that a good, strong provider recommendation makes most of the difference. Of all the other things we can talk about, that's the most important thing. And that also means, again, making sure your staff kind of has a similar presentation. And that means every vaccine equally recommended. We talk about that a lot with the HPV vaccine, where we don't want to leave that guy out and make it seem like, okay, you're due for these 2 vaccines, and then there's this HPV vaccine that you'll talk about with the doctor or something like that. So having really good communication, make sure that your practice is like a pro-vaccine practice and good scripting in that way. Beyond that, you talk about things like motivational interviewing, which Dr. Kaushik and I have been authors on a paper that talks about motivational interviewing that maybe we can put in the chat. That's one technique that's used for families that are hesitant. But probably the most important thing I always say is just if you continue to have a good relationship with the family, that's one of the most powerful tools, because if you can answer questions and don't assume that questions means refusal and continue to make that recommendation, that matters over time. It's not easy, and you're always going to have families that will not immunize or take those recommendations, but those are the most important tools that we have.
Excellent. Good communication. Thank you so much, Dr. Kaushik. Same question to you. What communication strategies have you found to be most effective in keeping conversations productive?
Yeah, thank you. So it's just like Dr. Boonstra kind of alluded to. First, we'll go inside, and being an expert, mostly the parents and the families are coming to me after they have had a conversation with the pediatricians usually. So then if they have not had a vaccine, or if it was just, falling through the gaps or due to, inadequate follow-ups, etc., I just see the discrepancy on the chart and then just say, hey, you're due for these vaccines. Would you like to have them today? Or if they are really in for a sick visit or an illness, then obviously, they can follow up with the pediatrician and get the vaccine. But then that is my recommendation in almost 100% of the conversations. Like, I don't leave the room without telling them that they are due for a vaccine and they should get it as soon as possible. Now, usually they don't give me a pushback. And if there is a family that's typically, the non-vaccinating types, and then you have to sit down if they have questions and stuff. So then we move on to the second part of it, which is motivational interviewing, which was alluded to earlier. So motivational interviewing, you really need to have that mindset that, okay, fine, I'm, going to talk to this patient family, but with a lot of patience. Just be very, very, you take the seat as a listener, and active listening is the backbone of motivational interviewing. So in our paper, as we had detailed, various scenarios, and I was also a part of the AAP body swaps VR module creation. As a national expert, we did create this motivational interviewing, was a part of, various scenarios presented to families that the pediatricians can learn a lot. And maybe Christina can also provide that as a resource after the meeting. so various scenarios to walk through, like, okay, if the parent is hesitant on certain questions, how do you approach that situation? So, of course, it's non-exhaustive, and we keep encountering new situations every day in the clinic, but it's just to give you a general idea of how to approach it. So, a sense is just having the listener seat, opening up your listening ears, and just having them talk out about it. So, opening up with an open-ended question, like, what worries you the most about this vaccine? Tell me about it. And then they can start off the conversation, and then you kind of affirm as well as reflect on the conversation, and then you take permission to offer your own advice and resources, and then at the end of it, you do close it with a statement that, okay, it's your, you are the main caretaker for your child, and I respect your decision, but then leave the door open for further conversations. In 99% of these kind of long conversations, hopefully it will end well, but sometimes it won't, and then you have to leave the door open for further conversations. But just to have that amicable relationship. Now, I know it's very testing. It's it's a testy time for the pediatricians, and I don't know how much um, time constraints also are there, right? So then again, infectious diseases is at your service. So you can always refer the patients to us. And I would say that for all the ID providers here on the call, like just utilize them as well for additional counseling if needed.
Patience and persistence are important qualities to have. Dr. Waddell, what communication strategies have you found to be most effective in keeping conversation productive?
Yeah, I think Ashlesha and Nathan both hit on really important topics. So I would echo their expertise in both of those areas. I'll just add a couple of things. One, I like one of the things Nathan said about presumptive and participatory. You usually don't walk in and say, "Hey, which hypertension med do you want your kid to get?" You know what I mean? So it's kind of comparing it to that is the same idea. And echoing something Ashlesha said is I like to start with questions. If I come out guns blazing about aluminum and they're like, "What are you talking about? I had no questions about aluminum," then you just open up a can of worms. So hear their questions, and then try and concisely address the questions they have and not open up new questions. And then the other, I think, so taking a step back, why are we having more of these conversations? One of the big reasons is because no one has seen the diseases, or few people have seen the diseases, in the 40s, 50s. The second biggest fear of the first biggest fear of Americans was the atomic bomb. The second was polio. And that is just not the case now. And so if you can't move the needle on some concerns families have with the risks of vaccines, I think having blunt conversations about the risks of the infections is important. That doesn't mean you're chastising or anything like that. You're just stating the facts of, here's what neonatal pertussis looks like. Here's what tetanus looks like when you don't get treatment or vaccinations, and giving a realistic risk assessment of the disease can be important.
I find it very fascinating that pediatric ICUs used to be tent cities in the summers with cases of polio, where we needed iron lung machines in summers. Thank you, Dr. Waddell. Dr. Kaushik, I'm going to come back to you. Some infections increase cancer risk later in life, and with cancer of special interest in our state, we know that HPV and Hep B infection can be prevented through vaccinations. How can pediatric clinicians and healthcare providers discuss this with vaccine hesitant families to better support cancer prevention?
Yeah, you rightly, mentioned, like, we just have very few vaccines to prevent cancer. Cancer is a big concern. It's one of the leading causes of death for all Americans, and it's such a scary disease. And out of all the cancers, only a handful are preventable. How cool is that, right? So I was actually in a room with hepatitis C exposed baby, not Hep B. Hep B exposed already get the vaccines, thankfully, according to even the federal recommendations. So, they already get the stuff, continue to get it. But so the hepatitis C exposed babies that we are seeing also in conjunction with syphilis in this area, I definitely make it a point even to talk to those congenital infection families. And that at least you got the Hep B vaccines. Thank God for that, because at least we can prevent what we can. We can't prevent Hep C with a vaccine, unfortunately. We only have it for a very few hepatitis-causing vaccine viruses at this point, and the major cause of liver cancer is Hep B. So prevent whatever you can, and of course, Hep A also you should get the vaccine, of course. But that's the thing that gets me really agitated, I would say it is the right word, that we just can prevent only a handful of cancers. Why not use that opportunity? And why are you criticizing even those handful of opportunities, like just on the basis of ideological thinking or whatever? HPV, I always talk to parents as the cancer prevention vaccine. Like, this is the big vaccine that prevents cancer, and really don't single it out ever. These are the three shots that are needed at your 11-year-old well visit, and that's it. And if you can combine all the 5 antigens together, and we do have an option, and those can be talked about later, like you do have several options available. You can pick and choose, but do vaccinate against everything. And then sadly, now we are leaving HPV and meninge out of the picture, like they have been dropped from the federal recommendations. But as before, AAP and the other organizations continue to recommend all the vaccination schedules, just like we were giving them in the past. So nothing has changed as far as I see in my practice and surrounding practices, thankfully. But coming back to your HPV and Hep B, these are the only 2 big guns that are saving us against cancers, liver cancers, and all the other anogenital cancers. Like when you present on HPV, it's alarming that how many cancers it can cause. And it's the number 1 cause of so many, not just the genital, but also the throat cancers. And, it's a big concern in the ENT world as well. So it's very important for us to be educating. And I think dentists and ENT providers can also help out with that, in addition to the pediatricians that's talking about it.
The CDC had an excellent graphic of an iceberg with the top being the cervical cancers and essentially the big chunk of the iceberg underneath being the extragenital cancers. Very eye-opening kind of graphic. Thank you. Dr. Waddell, question to you in terms of discussing these vaccines with vaccine-hesitant families. How do you support these as HPV and hepatitis B vaccines as cancer preventative vaccines?
Yeah, I think that when HPV vaccine came out, we kind of missed the boat on how we were advertising them from the beginning. So now we're trying to play catch up. But I think phrasing it as these are cancer vaccines, not sex vaccines, is important. So for hepatitis B, what I often will say here is, because if you think about it from the family's perspective, they're like, I don't have hepatitis B. I'm in a monogamous relationship. My 2-month-old is not going to be doing IV drugs. My baby can't get hepatitis B. And so it's understandable why they would think that from what we're hearing from different sources. So I like to remind people that of the tens of thousands of kids, about 20,000 kids would get Hep B every year. Half of them didn't get it from their mom. They got it from a washcloth, nail clippers, towels, things that seem minor. They didn't just get it from family. They got it from daycare workers, from friends, from extended family. And so I think that can be eye-opening for some people, and just hitting that point kind of hard. And then the one point I like to bring up with HPV is 85% of people will get infected with HPV. So you kind of akin it then to, are you going to be one who clears? Is your child going to be one who clears it when they get HPV? Or is it going to be Russian roulette and they get unlucky? So let's not play Russian roulette. Let's protect your kid from HPV. And I like to, one phrase is, let's protect your grandkids from losing their mom or dad too early in life. Because a lot of these infections happen, a lot of these cancers develop decades later. And so it's kind of hard to wrap your brain around that. But if you can kind of get them to say, hey, your grandkids might lose their parents early, that for some people can be effective.
That perspective on an ounce of prevention. Hepatitis B is not only acquired perinatally or through sex. I think that's a fantastic conversation. Thank you. Dr. Boonstra, same question to you.
Yeah, I think that HPV as cancer prevention is one of the most important messages that we can give regarding that vaccine. And it's absolutely the way that we want to frame it. When I talk with families in the clinic and talk with my 11 and 12-year-olds that are in for it, that's exactly what I say when I talk about the 3 vaccines that they're generally due for at that age. I again try to make it like we talked about with that announcement approach. I try to do it as a same day, same way thing, meaning that I talk about all 3 with the same level of detail. And when I talk about the HPV vaccine, I'm talking about, this vaccine is for this virus that causes cancer. It causes these kinds of cancers. And it greatly reduces and near eliminates a lot of those cancers. I mean, one of the things I think that is underappreciated is how very, very good it is at reducing the risk of cervical cancer and these other cancers. Cervical cancer being the most studied, and cervical cancer, basically nearly all cases of cervical cancer are HPV related cancers. Very rarely is it from another cause. So it is for the types that are covered in the vaccine, the cancer prevention is exceptional. So it's really just a matter of how many types we can get into the vaccine. So emphasizing that for families, I think, is the way to go with HPV. And yes, hepatitis B absolutely is the other vaccine that we have that can reduce cancer. It's not as one-to-one as HPV vaccine is, but talking to families when I counsel them specifically about that vaccine, same as what Dr. Waddell said. I counsel about that that risk of exposure at some point, and that vaccine covers them for a long time. They don't have to get re-immunized. They don't get another dose when they're a teenager. So why not have that early protection in case of any kind of things that involve even a microscopic amount of blood that can transmit hepatitis B?
Thank you, Dr. Boonstra. Yes, you have definitely a very direct way of communicating with your families. So I'm sure that's very, very helpful. Thank you. Christina, should we open it up to questions from our audience?
Yes,
I
absolutely.
think the
And
chat's been very active.
yes, it has. Some of those are resources that I will share in a follow-up email, so you don't need to save them to your desktop now. You will get them later. But we do have a couple of questions in the chat. So from Dr. Kest to Ashlesha. So we're coming back to congenital syphilis, and this is the topic. Are you seeing babies with symptomatic congenital syphilis, or is diagnosis mostly based on maternal and/or infant titers?
Thank you, Dr. Kest, for attending. So just wanted to mention that Dr. Kest is from New Jersey and is a very accomplished clinician, and we have done a lot of papers together, and she's been my mentor as well. So thank you for attending. Yeah, for the congenital syphilis, as we have also discussed in the past, what I'm seeing right now, in the beginning, there were a lot of babies and the wave has kind of stabilized, I would say. It's not like an upgoing wave, but still it's ongoing. And at this point, mostly they are in the possible category. So mostly, moms inadequate treatment and high titers, and that the baby's titers are positive and such. So mostly in that category is what we are seeing. But occasionally I've seen even symptomatic babies. I have seen babies with positive VDRL as well as with long-term sequelae. Hearing loss is the most common. And I have also seen a few babies with bony lesions, which is quite alarming. And there were a few other like rash type presentations and stuff. So abnormal LFT. So here and there, we have seen symptomatic babies as well, but mostly we have been just looking at, why we say that maternal titers and maternal testing and history of treatment is very, very important for diagnosis of syphilis. It's just not a singular or an isolated diagnosis based on the baby's presentation, etc. So we have to take the whole picture into account, and that's why these consultations take longer than usual. Thank you.
Thank you. Dr. Waddell, do you mind giving your perspective on the patients, the babies that you are seeing who are born to mothers with syphilis? Are you seeing symptomatic cases, or is screening and titers a significant driver of the diagnosis?
Yeah, for us here in Des Moines, it's kind of similar. Still, the vast majority of babies are asymptomatic, and we're picking up with screening. And since ACOG changed time, I don't remember time, like a year or two ago, screening moms throughout third trimester. We are picking up quite a bit now that we would not have picked up before. But similarly, we have seen a smaller percentage of kids who actually have symptomatic disease. One of the ones we saw recently had parasitis, and it was painful to watch. So yeah, kind of similar. Most are still picked up, and that's good. That a lot of the congenital symptoms can develop if you don't recognize it. So it's good that we're getting it early.
A lot of these symptoms do manifest later in life. Dr. Boonstra, are you seeing children coming in who are diagnosed with late
So
diagnosis of congenital syphilis?
I'm fortunate that I don't have a case of congenital syphilis to discuss, so I will defer to my ID colleagues on that.
Perfectly fine.
I'd like to keep it that way.
I don't blame you. It's a very confusing disease.
Which is not to say I'm not happy to care for any child that has it. I would like to not have any more children have it.
Yeah, absolutely. That's why I always say call ID. If you have any of these cases, these are very confusing. Christina, what else we got?
Yeah, fantastic. We have another question from Dr. Kest, and this will be open to anyone who wants to speak first. Parents who ask about vaccine ingredients often want more detailed information, and while the quantities of formaldehyde and aluminum in vaccines are small and considered safe, are there different categories or forms of these compounds? For example, those found naturally in food or the environment versus those used in vaccines?
I think I can start with this, if that's all right. So the formaldehyde, no different. So formaldehyde is a chemical structure. It does not matter where it comes from. It's not conjugated onto anything or anything like that. Formaldehyde is formaldehyde. So no difference there. And I also often will mention that in fact formaldehyde is part of our natural metabolic process. We make it and excrete it regularly. We make and excrete more formaldehyde than many times more as adults, certainly, as in a vaccine, and even a baby is making and excreting more formaldehyde as part of their basically your metabolic process for energy production. Just normally. So that's what I usually will bring up, that like your body does handle this. And the amount in a vaccine is tiny. When people get alarmed about formaldehyde, it's because you've probably heard about formaldehyde and cancer, but that is because we worry about chronic inhalation and things like nasopharyngeal cancers from chronic inhalation in environments like embalming and whatnot. So that's a way different concern than a small amount that you're making and excreting or that you would get from a vaccine. There's just absolutely no risk. The term drop in the ocean is really appropriate when we talk about formaldehyde in a vaccine. Aluminum is, of course, in different forms, different salts and whatnot. So yes, that can be a little bit more detailed conversation. And yes, it does matter ingested versus the fact that that's going to go through, not necessarily all of it's going to get absorbed, and then the whole hepatic pathway and whatnot. But so that's a little bit different conversation than in terms of the forms of aluminum. I do still, in general, as far as all aluminum sources, I do similarly talk about how we're constantly absorbing and excreting aluminum, and that there are actually fantastic studies on this. So that's when I do start to defer to the studies that, yes, we've actually studied aluminum in vaccines and amounts and neurodevelopmental outcomes, as well as looked at the basic biology, like basic pharmacokinetics of it, and looking at does that aluminum, when you get a vaccine, does it actually raise blood aluminum levels detectably? And it just does not.
Those metabolic pathways definitely scared me away from wanting to go into metabolics. Thank you very much. Dr. Kaushik, Dr. Waddell, do you have anything?
No, I think Nathan handled it perfectly. Yeah. No, the one would be extra would be mercury, ethyl mercury versus methyl mercury. The methyl mercury is the one that's has resulted in high concentrations, has resulted in actual diseases for occupational exposure, and ethyl mercuries in the vaccines. Very different. And when people say, why are we talking about organic chemistry? I always say, don't get your ethyls and methyls mixed up, or instead of a martini or an old fashioned, you can be drinking antifreeze. So the alcohols matter. Ethyl alcohol, methyl alcohol, same thing with mercury.
And then also just the fact that there is no thimerosal in vaccines. We haven't given a thimerosal-containing pediatric vaccine in ages. The only one that ever had it in the last 20 years was multi-dose flu shots, and even that has been decreasing over time. And now I think with the new regulations, it's not in any in the United States. So it's really a non-conversation at this point to talk about thimerosal. If family brings it up, you can reassure them that it just doesn't exist in the shots.
Yep, I would completely agree with that, and that's why, we had previously stated the things during our presentation and the questions. But one thing that I would also like to say is that the breast milk analogy, also like aluminum is much more in breast milk or in the formula rather than any kind of aluminum that's used in very, very minor quantities for increasing efficacy of vaccines. So that's also important.
Christina, I believe someone has their hand raised.
Yes, Dr. Niwas, please feel free to let us know your thoughts.
Yeah, thank you for such a great presentation about vaccine. I'm a neonatologist and I just work in an ICU, don't run the follow clinic. So I had to deal with the questions about
Patient
vitamin
was in
K.
for a follow-up period. She was recently admitted to the hospital.
Sorry, Dr. Niwas. Go ahead.
Yeah, so I had to deal with only vitamin K and hepatitis B vaccination. Vitamin K, of course, parents are convinced because they want the baby to be circumcised because we don't offer the vaccination if they don't receive intramuscular vitamin K. About hepatitis B, we are not able to convince them for their birth hepatitis B vaccine. So because they have already made their mind. If my ID colleagues are consulted, my question is that what percentage of these parents you are able to convince?
Dr. Kaushik, Dr. Waddell, do you have experience having these conversations in the newborn period, and how successful have you been?
To be really transparent with you, not terribly successful changing their minds in the newborn period. Like you were saying, a lot of people have already made up their mind and done their own research before the baby's born. This is one time where it gives me a slight pain to say, yes, let's prioritize vitamin K in these situations. So my goal is to, if I can't change their mind, is to leave the door open that let's get this at 2 months. And that has been, I'd say, I don't know, maybe 50-50 that, hey, yeah, we can redress this and get the shots at 2 months. But I haven't had a ton of success with the birth dose at Hep B.
Thank you.
So actually, sometimes even like we have had situations, and those are quite alarming situations in which hepatitis B positive moms, sometimes, they have shown resistance to have the vaccine given to the baby. And in those situations, of course, one has to be very, very persuasive for the baby to get the vaccine. And again, as Dr. Waddell rightly said, if they don't listen, then you just keep the doors open for further counseling at 2 months, because we don't want them to completely skip on the vaccines. Like they do have to make the 2-month visit for the rest of the vaccines, right? For the first dose of every other vaccine, and then we can address Hep B. And we do have at least till 6 months, we have the leeway of, vaccinating in Hep B positive babies. Of course, the chances of getting it perinatally from the mom are largely prevented by the birth dose and the immunoglobulin. But if that's circumvented, then you can do whatever you can, right? So whatever is in your hands, at least don't want to miss out on the 2-month, 4-month, and 6-month well visits in that case.
It's been a few years since I've done newborn nursery as a general pediatrician. We have, newborn special, and by a few, I mean probably 10. But I did used to counsel families on this a fair amount, and I'll counsel them if they refuse and they come in then, a couple days later to my clinic, I'll counsel. And I agree. It's a more difficult conversation. Again, if we're talking about hepatitis B negative during pregnancy, we know that's a low but not zero risk for the baby to have been exposed to hepatitis B. So it really does for me feel like a conversation that's more, I'm going to explain and give my recommendation. And then that decision that's made by the parent, we're going to go with, and we're going to, revisit it at 2 months. So when I give that explanation, so I remember doing this in newborn nursery, they refuse. I would make point to go into each of these families, at least sit down and say, here's the explanation. And I agree also, vitamin K risk-wise, that's the priority. I'm more worried about a refusal of vitamin K than I am about hepatitis B. So if it is a situation where it seems like I'm recommending everything and they're going to refuse everything, focusing on that vitamin K is important to me. But if I sit down with the family, I will say, look, this is the reality. Even though we test for hepatitis B during pregnancy, we know that there's a false negative rate to testing. We know that there's the possibility of exposure to hepatitis B later in pregnancy. And we know that at least some people who are presumably born to a hepatitis B negative pregnancy actually do have exposure to hepatitis B. And the reason that this is a big deal is because the consequences of missing a case are so devastating. A teenager or an adult that gets hepatitis B, they're going to go through acute hepatitis B, but they're unlikely to have that virus living in their liver for the rest of their lives. A baby that gets hepatitis B is likely 90% plus likely to have chronic hepatitis B and live with that virus for their life. And that baby has a 25% chance of dying from that, from liver cancer or liver failure in their average ages in the 40s. That's very bad. So we want to catch everybody. So that's why we recommend it for everybody. And that way, I think that helps in terms of at least presenting it as like, we're not judging you. We're not saying that you have hepatitis B. We're just saying we know statistically this can happen and the consequences are bad. This is why I recommend it. And then I leave it to, that family to ultimately decide and make sure their questions are answered and then revisit it at 2 months.
Yeah, that scenario of vaccination in the newborn period really speaks to the importance of that long-term relationship between parent and pediatrician, and how as one-time consultants we're not often that effective to say, hey, I've never seen you before, I'll never see you again, here, let me convince you. So that long-term relationship for pediatrician relations is important. Christina, anything else?
Yes, we do have another question here, and I recognize we're close to time. So if there are additional questions later on, I will make sure to share that with our panelists to send responses and follow-up. But Dr. Conti asked, and I'm going to look to Dr. Boonstra first since it referenced general peds. When you provide reference literature for vaccine safety, how often do parents decide to get the vaccine, or does the presentation of research literature work to convince?
It's not super often that I just present research directly in the clinic, right? So I'll talk in general about a study, and then if they really want to look at it, we can look at it together. So if you're talking about that kind of literature, probably not super often. One of the things I do know, though, is that I'll have the occasional family that now that we have a lot of electronic communication, that they will, I invite all my families, and partly I'll admit this is because this is a special interest of mine. So it brings me great joy to be able to answer questions and dig into these questions and stuff. But I encourage them, if you have questions about immunizing, please send me the link that you read or the Facebook post. Send that over the portal, and I'll look at it and I will send you stuff back about it because I've probably seen it before. And so that's something that I really think can be helpful if you have a vaccine hesitant family, if you can make yourself available to do those things. Obviously, we all have time constraints, and if you have 100 families doing this, that's going to start taking up a lot of time. But I think that is something that families knowing that I'm not going to just shut them down, and I'm going to be willing to answer those questions, even not right here at that visit, I think is really helpful. So that's a time when I will send them a paper. Or I'll say, here's a study that actually specifically looked at the concern that you have, and I can send it directly to them. One of the tricky things, I'll add this too. One of the tricky things is too, we know that vaccine, especially those early vaccines, they're time sensitive. We don't want to delay too long because we know that whooping cough is around now, and we know the babies are vulnerable now. And so especially with a 2-month visit, every 2-month visit, if they're vaccine hesitant, I'm always like, okay, but we have to have the pertussis conversation. We have to talk about that vaccine specifically now, which is the most time sensitive. All of them are important to get on time, but this is a very, very time sensitive one. And so try to, kind of in the same way as like, if I'm going to think about vitamin K as the most important, there are definite times where I'm going to recommend all the vaccines. There's no question I'm going to make that recommendation that you should get them all. But then I'm going to focus in on, hey, this is the importance of pertussis vaccinating at this age right now.
Turning over that rock. Thank you so much, Dr. Boonstra. Christina, I'm going to move to our closing questions, maybe if you're okay with that, for time purposes. But I want to thank all of our panelists again. Thank you so much to all of you for providing your insight and your expertise for this conversation. For our final question, could you, and I'm going to start with in the same order we did introduction, so I'll start with Dr. Kaushik. For our final question, could you please share one key takeaway you would like our audience to remember from today's discussion?
I think the most important takeaway from today's discussion, and I know everybody's so busy in today's world, is to give a strong recommendation and then to leave the door open for conversation. So you don't want to burn bridges, but just to maintain that cordial relationship, because the whole trust in the, that you are the basic caretaker for the baby, right? You are pediatricians, you are ethical, moral, altruistic medical professionals. That's the main reason why we chose this field in the first place, right? So if that entire thing is under pressure right now, I mean, we need to just keep up the flame and just keep going with our good spirits and just maintain the basic confidence, I guess, that we are the experts, and no matter what, we know the true science, and let's just stick by the science and keep doing the good work. Thank you. Thank you.
Dr. Waddell.
Yeah, thanks, Lucas, for moderating this. It's been great. The one thing I would recommend is, as a kind of a blanket statement, would be that I call it your elevator speech. Have your elevator speech 2-3 sentences for the highest yield vaccine myths. That way you can seem confident, concise. You're coming back quickly when they bring up things. You don't have to go into the weeds in every single myth out there, but if you have your top 5, top 6, have your 2-sentence rebuttal ready.
Perfect. And Dr. Boonstra, your one takeaway for our audience.
Yeah, I would probably add to that. I guess I feel like 20 years ago when I started, I was also very interested in vaccine information, and when I started practicing, and I would take more, not personally, but like I would worry more about my family's refusing and what that means, and how like I wasn't able to convince them and feeling like I wasn't doing a good job. And as the years have gone on and recognizing the incredibly complex media environment, political environment that we are experiencing right now, that I do think it's important for people who are very pro-vaccine, very much wanting families to immunize, to also recognize that you can do your best, and that there's a certain amount of investment you should make. And then you have to recognize that conversation isn't always going to go the way that you want. Give them the best information that they can, hope that they make a good, healthy decision. And then if that ultimately then is not actually a situation where they end up vaccinating, be willing to revisit and answer those questions, but understand that you did what you're supposed to. You did the best job that you could making that recommendation for that kid, and then move on to the next best right choice.
Thank you very much. And I know we're out of time, but I'll give one takeaway from my perspective. And we kind of alluded to, we talked about this earlier in the conversation. I would encourage remaining non-confrontational. Yes, give your recommendations, do your best as a pediatrician, as a provider. I have a thank you card pinned up in my office from a vaccine hesitant parent, basically thanking for being non-confrontational. Be the listener, listen and address their specific concerns. It can be very frustrating, but that card really reinvigorated me and kind of filled me with hope. Hard to come by nowadays, but keep it up, everybody. Doing the best they can.